Good afternoon, everyone. Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to leave your questions to the end. Please enter them in the chat. And as well, please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you were present today. We have an invited speaker today and from the Division of Rheumatology, and I'd like to ask my esteemed colleague, Dr. Ines Colmena, to please introduce our speaker. Thank you.
Morning, and thank you very much for joining these rounds. It is really my pleasure to introduce Dr. Maria Suarez-Almazor. She's a rheumatologist and a clinical epidemiologist with a long-standing career in comparative effectiveness and outcomes research. She comes from the University of Texas, specifically at MD Anderson Cancer Center. Her clinical areas of practice are rheumatology and clinical immunology, primarily in cancer patients and survivors. And she's interested specifically in immune checkpoint inhibitors effects, which is a topic that she's going to talk about today. Dr. Suarez-Almazor has been a principal investigator in many studies funded by the NIH, AHRQ, and various foundations. She has mentored over 50 trainees and junior faculty, and she's the director of Comparative Effectiveness Research Training and Instruction, a program funded by the NCI to provide methodological training, including the use of large databases for outcomes research. So really, we look forward to learn from Dr. Suarez-Almazor, and by doing that, try to help better the patients that we have here. Thank you.
So thank you so much, Dr. Colmena. It's a pleasure for me to be here, something that Inez didn't say, but I spent many years in Canada, about 16 years at the University of Alberta in Edmonton, so it's always a pleasure for me to come back home in a way. This is also home for me. So, okay, so I have no disclosures with respect to this talk. And I'm going to give you a little bit of an overview about immune-related adverse events caused by immune checkpoint inhibitors. Then we will talk about rheumatic immune-related adverse events and a little bit about challenges in management. And at the end, I'm just going to show you what we have been doing at MD Anderson in general for immune-related adverse events on what we call the IO-Tox initiative. So, as you know, cancer immunotherapy has changed the landscape of cancer management, and you may have seen this photo before. This is a photo of or a picture of a patient who had melanoma at screening. He had lesions, and then as the disease progressed, he was treated with ipilimumab. And as you can see here in the picture, after treatment, his lesions were even larger, and once the treatment was stopped, the lesions started to regress. The reason why I like to show this is because it shows how this treatment is very different from what chemotherapy would be. You stop chemotherapy, the effect goes away. With immunotherapy, the effect can continue, but also can the immune-related adverse events. And that's something that we see in rheumatology that maybe in other specialties you don't see so much, but that some of the manifestations that we see as toxicity of immune-related, or as toxicity of checkpoint inhibitors or immune-related adverse events such as arthritis can linger for months even after we stop the checkpoint inhibitor therapy. So the immune system has checkpoint mechanisms to avoid persistence of the immune response. If those mechanisms were not in place, what would happen is that the inflammatory response would continue, and then we would have damage to the normal tissues. So basically, these mechanisms downregulate the antigen presentation T cell interactions, and tumors are very sneaky, and they can enhance some of these mechanisms to try to escape this immune response. So immune checkpoint inhibitors are monoclonal antibodies that target these mechanisms to allow this immune response to continue. There are three primary pathways that have been investigated and for which agents have been developed: CTLA-4, and the drug that's been approved is ipilimumab, then drugs that target the PD-1, PD-L1 pathway, and then more recently approved the LAG-3 pathway as well. So you're probably familiar with signaling of T cell, but I'm just going to go and move the mouse slowly because I just made it bigger. Okay, in order for T cell activation, there needs to be what's called co-stimulation. So here you have the major histocompatibility complex, the antigen and the T cell receptor. In order for activation to happen, there needs to be this coupling here, which is what's called co-stimulation. The minute that happens, in order to be able to stop this immune response, the T cell starts expressing a CTLA-4 receptor on its surface that has high affinity for the B7, and that way the immune response stops. What ipilimumab does, it's an antagonist for CTLA-4, so it's a monoclonal antibody that blocks this response. It's the opposite of what we use in rheumatology, which is a CTLA-4 agonist, which is an immunosuppressor, and it's a abatacept, and you might have heard of abatacept. So ipilimumab is the opposite of abatacept. The other mechanism of action that's much used in oncology and that has approval for many more cancers than ipilimumab is the pathway of PD-1 and PD-L1. So this is a little more complex, but you can see that on one hand, the same sort of pathways occur with the T cell antigen-presenting cell interactions, but in addition, tumor cells express PD-L1. And as the tumor progresses, this inhibits the immune response. So by using monoclonal antibodies that can attach to either PD-L1 or PD-1, we inhibit the inhibition and we allow the immune response to continue. There are many targets that can potentially be used in cancer immunotherapy. LAG-3, which I mentioned, is here. Some of them are inhibitory receptors, and others are activating receptors. So the ones that have been approved for use are the ones that are inhibitor. So the agents are monoclonal antibodies that block those responses. But conceivably, there could also be agonistic antibodies that would enhance the immune response. So the current trends are, there's an exponential use in checkpoint inhibitors. There are new drugs within the classes and the pathways that I mentioned, but there are other checkpoint mechanisms that are being studied. There's also a trend for earlier use. Now these agents are being used as adjuvant and neoadjuvant therapies. Before they were approved only for metastatic disease. And there's also combination with other therapies. So combination between checkpoint inhibitors, for instance, ipilimumab and a PD-1 agent, combinations with chemotherapy, with targeted therapy or radiotherapy. What this does is it makes the entire spectrum of adverse events more complex because it varies according to whether it's just immunotherapy alone that has been used or immunotherapy with targeted therapy, for instance, that has its own spectrum of adverse events. So we are going to see an increase in the incidence of immune-related adverse events because they are being used more. There's better efficacy with the use of combination therapies, but there's also increased toxicity. And what's important when one is discussing with patients whether to continue or discontinue treatment is that harm-benefit ratios vary according to disease stage. So before we were just using these agents for metastatic disease, but now that they are using adjuvant and neoadjuvant settings, the harm-benefit ratio may vary a little because many of these patients could potentially be cured just with their surgery or with another therapy without having to use immune checkpoint inhibitors. So if there is toxicity, the threshold for stopping therapy is going to be lower than if the patient doesn't have any other option for oncologic therapy. So immune-related adverse events are off-target inflammatory and autoimmune events that occur with these agents. They happen quite frequently, and they can be severe and life-threatening. There are differences according to the pathway that's being targeted. And for instance, in knockout mice, in the model of CTLA-4 knockouts, the mice die from massive lymphoproliferation and autoimmunity. With PD-1 knockout models, it's a little different. The disease is more limited, and there's more organ-specific autoimmunity. So we know already that there's going to be differences in the spectrum of immune-related adverse events according to the drugs that are being used. This is a graph from the New England Journal of Medicine that had a number of organs that can be off targets of these agents that can have toxicity. And I have to say that I had to add many of the rheumatologic ones because they were not initially recognized. But I just have in red the ones that we see in a rheumatology, and those are the ones that I'm going to mention as I move along. So what's the probability of getting any immune toxicity? This is from real world data. So you can see at 12 months, the probability of toxicity is 51%. So this is pretty high. This is pretty impressive. And what people may not recognize is what's the probability of ongoing immune toxicity when we look at community data or real world data. Here it's 24 months. And you can see that at 24 months, about 35% of the patients are likely to continue with toxicity, even after some of them have discontinued checkpoint inhibitors. Then there is always a silver lining for everything that's bad. And the good thing here is that if you look at patients here, the green one, the green line is patients who have immune-related adverse events. This is lung cancer, this is melanoma, and these are the ones who did not have immune-related adverse event. And the shadow the shadow area is the confidence interval. And you can see that overall survival is better for patients, both in lung and melanoma here and here, that had toxicity, that had immune-related adverse events. This shows pretty much the same concept. This is a meta-analysis of various studies that examined progression-free survival in patients with and without immune-related adverse events. And what it showed, 1 would be neutral, so no difference. And this is below 1, so there is a benefit in those patients who had immune-related adverse events. And if you look, these are the individual studies, so you can see they are all trending towards benefit. And this is a pooled average that shows that patients who have toxicity actually do better with respect to their tumor progression. So if we look a little bit about, we think a little bit about immune-related adverse events and compare it to other therapies in oncology. If you have chemotherapy, for instance, almost those chemotherapies that make you have hair loss, almost everyone has hair loss. If you're going to have nausea, almost everyone has nausea. With these agents, it's very different. Not everyone gets immune-related adverse events, and some people may receive these agents for years and never have an adverse event. Others may receive 1 dose and they developed a severe immune-related adverse event. So it's not necessarily dose-dependent. Phenotypes vary across individuals. So some individuals may have a single adverse event, others may have many different events. The organs vary as well. Some of them occur very early on, for instance, myocarditis or myositis. Those tend to happen with 1, 2, 3 doses. Others may happen months after the patient has been in treatment. Some resolve with the ICI discontinuation, others persist even if you discontinue the treatment. And then there are differences across the type of agent that you're using. As I mentioned before, and here I have a typo, it's hypophysitis, what it's meant to be. Some, for instance, CTLA-4 inhibitors are more likely to cause hypophysitis or colitis than the PD-1 inhibitors. There's also differences across tumors. For instance, pneumonitis is seen more frequently in patients who have lung cancer. So why is this happening? Well, we think there are genetic differences, which might be germline genetic differences. There's differences in microbiome. There are some environmental differences, and this is an area that's becoming more studied now, differences with respect to lifestyle factors such as smoking, diet also, and even drugs. There are some drugs that seem to be related to better or worse response of the agents and more or less prevalence or incidence of adverse events. And then there's also subclinical pre-existing autoimmune disease that may not have manifested, but if a patient receives a checkpoint inhibitor, then they may develop full clinical autoimmune disease. For instance, rheumatoid arthritis, there's studies that have shown that some of the patients who developed seropositive rheumatoid arthritis, they already had antibodies because they look at the sera from patients that had blood drawn before they started therapy, and they found that those antibodies were already present before they developed the disease. So these are just some examples of studies out there. This is one study that we did a few years ago, and what we found is that there were different variants. When we were comparing, these were just patients with melanoma, with and without immune-related adverse events. And for those who did not have immune-related adverse events, we waited for an entire year. So we required them to have at least 1 year where they hadn't developed any adverse events. And then we found different SNPs that were correlated with or without the adverse events. So there seems to be some differences, genetic differences, and there have been other studies that have looked at that. This is another study that's interesting, and I'm just going to show a few examples. In this study, they looked at the polygenic risk for skin autoimmunity. Basically, one of the diseases they looked at was psoriasis, so they examined the genetic markers that are associated typically with psoriasis, and what they found is that these genetic variants were related to patients developing skin toxicity when they received checkpoint inhibitors, independently of whether they had psoriasis or not. Just because they had these markers, they were more likely to develop any type of skin rash with checkpoint inhibitors. And they also had better survival. And that goes back to what I said before, that the silver lining of all of this is that if you have adverse events and they are not bad enough that they can cause morbidity or even mortality, then you might do better with respect to your tumoral responses. This is another study that looked at intestinal microbiome analysis. And what they found is that different microbiome signals in your colon were related to, in this particular study, but there have been many studies. I'm just showing one as an example. Here, if there was an increased representation of bacteria in the Bacteroidetes phylum group, that was correlated with less incidence of colitis. We also know that the microbiome influences the response, the tumoral response to checkpoint inhibitors, and some patients with specific microbiomes, they are likely to respond better to some checkpoint inhibitors. So this is also playing a very important role, and there are trials ongoing with how one can use different diets to try to maybe enhance the efficacy of checkpoint inhibitors in patients. This also shows lifestyle factors. So this is a study that looked at smokers versus non-smokers, and they found that smoking status was also associated twice-fold with the development of immune-related adverse events. And this was not just pneumonitis, as one might suspect. It was also other adverse events such as dermatitis or thyroiditis. So with respect to the pathophysiology, that was more of the risk factors or etiology. Well, the pathophysiology is also an area that's being studied very heavily, because the idea is to try to identify how we can stop these adverse events from happening without impairing the tumoral response. So ideally, one would like to find whether there are specific pathways that we can target with our treatments of toxicity without really making the tumor worse. So first of all, we know that in general, there's an unrestrained immune activation that happened with the use of these agents, especially we think more with ipilimumab than with some of the more with the other therapies such as PD-1, PD-L1 inhibitors. Some of the immune-related adverse events appear to be almost more inflammatory or related to innate responses, for instance, dermatitis, colitis. And they tend to occur very early on, and when you stop the therapy, they usually go away. Others appear later on, and they can be more difficult to treat, and we don't know yet, and arthritis would be an example, if there's a bigger role of adaptive immunity in the development of these particular toxicities. The one of the things that has been found is that, and I mean, this is rare and it has only been described for hypophysitis, but CTLA-4 is expressed in the hypophysis. So one of the reasons why with ipilimumab, which is a CTLA-4 inhibitor, we may see hypophysitis is because of the direct effect of the monoclonal antibody on that particular tissue. So direct effect of the antibody affecting the tissue. But we don't think that this is a mechanism that occurs more frequently, but it has been described for hypophysitis. Then there's a whole issue about cross-reactivity. between the tumor and then an off-target organ. Vitiligo could be one of those examples. Patients that, and actually they tend to respond better, patients who have melanoma, but it's also been described in some who don't have melanoma. When they get these agents, they may develop vitiligo. So it's thought to be a cross reactivity with antibodies that are produced against melanocytes, both in the tumor and in normal skin. Then there's generation of autoreactive T cells within the tumor milieu, and also whether these can be activated in off-target organs, causing some of the effects that are not related to the organ with the actual tumor. This is one paper that was published a few years back, and what they were able to prove is that there was cross-reactivity, and this was with T cells between the tumor tissues and the myocardial cells. So they were able to prove that in, I think it was 3 patients. Okay, so this is from McGill. It's a paper that proposes immunopathogenic pathways, and it covers much of what I've said. On here, breach of self-tolerance, then cross-antigen reactivity. So here, this would be the example that I said of vitiligo. Off-target effects here, this is the hypothesis. Then cytokine, chemokine production, this is the more widespread and restrained immune response. And then here, the effect of the microbiome. So this is an excellent article, an excellent review that I recommend that people read. Okay, so moving along, I'm going to talk now about rheumatic immune-related adverse events. Those are the ones we treat in our clinic. And they are not as frequent as some of the other immune-related adverse events, but they affect approximately 6 to 7% of the patients. Initially, they were not as recognized in the clinical trials because many of the trials would report grade 3, grade 4 adverse events, and sometimes arthralgia or arthritis wasn't considered at that level. So at the beginning, they were not as recognizable, but as these agents started being used in the community, then we saw that 6 to 7% is fairly common, I would say, but not as common as, let's say, rash or maybe colitis with, especially with ipilimumab. So we find arthralgia and arthritis more common with the anti-PD-1 or PD-L1 agents or in combination with ipilimumab, so anti-PD-1 plus ipilimumab. It can present as arthralgia, arthritis. There's also polymyalgia-like syndrome, which has an overlap with the arthritis. We also see patients who present as Sjögren syndrome or Zika syndrome, then myositis, sarcoidosis, and other miscellaneous diseases, which are more infrequent. We also see patients who have pre-existing diseases, and they may have exacerbation when they receive these agents. Because we don't have a lot of time, I'm not going to talk about that population, the population of patients with pre-existing psoriatic arthritis or rheumatoid arthritis. I'm just going to talk about de novo rheumatic adverse events. So this graph shows a little bit the timing, and if you recall what I mentioned before, some of these adverse events happen, in general, very early on. For instance, rash, you have here in red, rash, so it can start happening as soon as 2 weeks after a patient starts treatment, so just with 1 dose. Myositis, which is one of the ones we see, it also starts fairly soon. So it would be extremely rare to have myositis after 6 months of treatment. If the patient doesn't develop it early on, then they will not have it. Arthritis, on the other hand, it tends to start later on. Okay, so we don't see generally arthritis within 1 week after the first dose of treatment. So inflammatory arthritis, generally, we can see it as arthritis with joint swelling, but sometimes patients also have severe arthralgia with no joint swelling. There are very many different patterns that we can see, and we don't know right now if they represent different diseases or if it's the same disease manifesting a different phenotype. Anyway, so these are the different patterns that we might have, mild to severe arthralgia, and sometimes that's in overlap with polymyalgia. Seronegative polyarthritis, that's the most frequent phenotype that we find. Sometimes it's okay. Patients might have what looks like rheumatoid arthritis with positive autoantibodies, but that's the least frequent presentation. Less than 10% of the patients will have rheumatoid factor anti-CCP. Other patients present with oligoarthritis, generally large joints. It could be the knees, it could be the wrists. Some other patients may present with features of spondyloarthritis, so they may have back pain. Psoriatic arthritis is also another presentation, and we have seen patients who only had skin psoriasis for a number of years before they got cancer and before they got their checkpoint inhibitor, and then they developed psoriatic arthritis with a checkpoint inhibitor. RS3PE, that's remitting seronegative symmetrical synovitis with pitting edema. That's another phenotype that can occur. And actually, there is a series from the Canadian Registry of Rheumatic Adverse Events, the CanRIO registry, with a report of a case series. And some patients will present just with tenosynovitis, so that's inflammation primarily of the lining of the tendons, and we have seen a few patients like that. Okay, so this is from a study from Laura Capellis in Johns Hopkins group, and these are the patients at Johns Hopkins. They probably have, as a single center, the best documented patients to date, and they were trying to find what could cause or what were the effects of persistent arthritis. The first important thing that I want to show you here, if you see the bottom line here, this is the follow-up in months. And here on the y-axis is the patients with active inflammatory arthritis. So you can see that unlike what we see with other immune-related adverse events, these are months, okay? So if I look at how many patients still had active, for instance, 50%, I mean, you can see that almost up to, depending on the line that we're looking at, but that, 1 year after they received the checkpoint inhibitors, at least 50% of the patients still had active arthritis, and these are patients that were treated. So what we have in the first graph is patients who received monotherapy and patients who received combo therapy. So this is an anti-PD-1 and ipilimumab. And you can see that arthritis was much more persistent in those who received combination therapy. Here, what they looked at is the influence of having more than one adverse event. So here are the patients who had two or more adverse events. They also had more persistent arthritis than those who had only arthritis or had only one additional adverse event. And again, the silver lining, this is the last one. They looked at patients who had complete remission, and these are the patients here, and patients who only had partial remission this is complete remission or partial remission, and these are the patients who had progression. And you can see that the ones who did better with respect to their cancer also were more likely to have persistent arthritis. So treatment recommendations, the goals of therapy, something that's very important, especially in patients that may not have other options for oncologic treatment, is to try to continue the checkpoint inhibitor therapy. So that's always something that is in our mind. What can we do so this patient can continue treatment, especially if they are responding well to the treatment? And then we also want to improve the quality of life of patients, because obviously arthritis is painful, it's debilitating, and it impairs activities of daily living. Typically, we try to use at the beginning a dose that's not more than 20 milligrams of prednisone, because we are concerned about the effects of prednisone. But doses less than 20 milligrams usually are not as effective. If it's very severe, we may use even 40 milligrams of prednisone, but try to taper it very quickly. If the patient does not respond, we very quickly try to start using disease-modifying anti-rheumatic drugs. And what to use is still under debate. And I think there's practice variations across centers and also across countries. I think in Europe and in Canada, from what I hear, methotrexate is used quite a bit. We don't use, we sometimes use methotrexate, but our oncologists don't really like us to use methotrexate. They are convinced that it's not as safe, and we always try to get patients, if they have persistent disease, on biologics as soon as we can. Sometimes it's difficult because it's not approved by insurance, and then we do what we can. In our center, the class of agents that have been used the most is TNF inhibitors, from what we see in the data series from different centers when we look at the use of biologics. In our center, we try to use more IL-6 receptor inhibitors because we think there's no major signals with respect to IL-6 inhibitors making cancer worse, and there's some data in melanoma that would suggest that IL-6 is detrimental for the progression of melanoma, so IL-6 inhibitors could potentially be useful. It's unclear if there are advantages. There are not very good, large control series to be able to really say this approach is better than another approach. So the key points about arthritis is pleomorphic. It can present as oligoarthritis, polyarthritis. It usually occurs after several courses of treatment, and there are cases described, and we've had cases at MD Anderson when it happened after the discontinuation of checkpoint inhibitor therapy. So, for instance, patients stop because of progression of disease, and a month later they develop arthritis. It's worse with combination immunotherapy. Generally, it's seronegative, so rheumatoid factor and anti-CCP are negative. Some patients were found to be seropositive before checkpoint inhibitor treatment. So in those cases, we think it's probably just rheumatoid arthritis that became clinical with the treatment. It can be chronic and erosive, and it's more difficult to treat than other immune-related adverse events that are treated and you discontinue the checkpoint inhibitor and then it tends to go away. So again, the goal is to try to maintain the patient on the checkpoint inhibitors while minimizing symptoms. So polymyalgia rheumatica, it's a little different in patients with checkpoint inhibitor compared to patients with primary polymyalgia. The criteria for polymyalgia say that patients should not have concomitant arthritis, but in these patients who have received checkpoint inhibitor, it's not unusual to find them with the symptoms of polymyalgia, so proximal pain, but in addition, they may have peripheral arthritis with synovitis of their joints. Very rarely, it has been described with giant cell arteritis. In my particular practice, the only ones that I've had with giant cell arteritis are, there's a couple of patients, but they had temporal arteritis before they received the checkpoint inhibitor. So I haven't seen anyone with polymyalgia and giant cell arteritis de novo after checkpoint inhibitors, although it has been described in one or two case reports. It improves with therapy discontinuation and steroids, but usually patients flare with the re-challenge, and sometimes it requires the use of IL-6 inhibitors, which are have been they are not approved for polymyalgia. They are approved for temporal arteritis, but they have been shown to be useful for refractory cases of primary polymyalgia rheumatica. So that's what we would use. Zika syndrome. This presents a little bit like Sjogren. I call it Zika syndrome because it seems to be somewhat different from primary Sjogren. Dry mouth is much more common than dry eyes in patients who develop this after checkpoint inhibitors, and very often the onset is acute. There can be swelling of the salivary or carotid glands, and the Schirmer test, which is a test in the eyes, might be negative because oral is affected much more than eyes. If the patient only has a little bit of dry eye, you always have to think, is the patient antidepressants? Could it be the chemo? This usually, when it presents, is very florid. It's very severe when it's related to immunotherapy. The majority of the patients don't have the antibodies that we see in primary Sjogren, so they are negative for SSA, SSB, and ANA. And we treat them symptomatic or may require steroids and then DMARDs if they do not improve. So this is from a series of patients that we are part of a registry that sits in Europe, but different centers provide cases of patients with the more unusual adverse events. So this is a paper that was done in patients with Sjögren's syndrome triggered by checkpoint inhibitors and comparing to primary Sjögren's. So there are several differences. Primary Sjögren's occurs primarily in women, and in checkpoint inhibitor Zika, it's half and half, so that does not happen. As you can see, dry mouth is very common, but dry eyes are not as common compared to primary Sjögren's. The antibodies tend to be negative as opposed to primary Sjögren's that usually has positive antibodies. And the biopsies also show a different immunohistopathology with more CD8 positive cells in the ICI induced compared to the primary Sjögren's. So is this the same disease or is it something different? We don't really know, but it certainly presents a little different than what primary Sjögren's would present like. Myositis. This is the one that we worry the most about of all of the ones that we see in rheumatology. Patients present clinically as polymyositis, so they don't have the dermatomyositis that you see more with what's called paraneoplastic myopathies, or which tend to be, for the most part, dermatomyositis affecting the skin. Here, the patients have polymyositis. It tends to be very acute, and because it's that acute, patients often will have pain, which you don't see in primary polymyositis. Most patients just have weakness, but some of these patients have actually muscle pain, and they may have necrotizing myopathy and rhabdomyolysis. Many of these patients also have myocarditis, and that's what makes this very severe, as the mortality rates for patients who have myocarditis is high. Occasionally, there is an association with myasthenia gravis syndrome. It presents as myasthenia gravis also, and that's what people call the triad, which will be myositis, myocarditis, and myasthenia gravis, and that has the worst prognosis of all. So the current thinking is that this is a different entity. It's not a paraneoplastic dermatomyositis or myositis that's being made worse or becomes clinical because of the checkpoint inhibitors. It's thought to be something different. So this is our case series, and this is a little old. It's from 2020. We haven't reviewed the series yet, but we had of over 9,000 patients who had been treated with checkpoint inhibitors, 36, so 0.4% had myositis, and this was 3 times more common with combination immunotherapy versus monotherapy. The median time from initiation of treatment was 27 days, so 2 doses. So this happens very early on. And many patients had severe symptoms. About close to a third had rhabdomyolysis, and over half have some overlap manifestation. Not all the patients have autoantibodies. When they have anti-acetylcholine receptor positive antibodies, we tend to think that there's an overlap with myasthenia gravis. The other antibody that we have found, here in 46% of the patients, was anti-striated muscle antibody, and in some cases reported in the literature, these antibodies, the same as for the rheumatoid factor, were also found to be present before the patient received the checkpoint inhibitors. So we still don't know if there is a predisposition because of the existence of some of those antibodies in patients prior to treatment. So if patients only have myositis, we find that the response is very good. They respond very well to steroids, and the CK normalizes very quickly. And most patients have no further flares if you don't restart them on the checkpoint inhibitors. If they have the overlap, there's a high chance of mortality. It's much more difficult to treat. And in our center, they are treated very aggressively. Usually, it's cardiology that calls the shots, and Patients receive high-dose steroids, plasmapheresis, and 1 or 2 biologics almost immediately. In our series, about a third of the patients died from sepsis because they were treated so aggressively. So that's also something that one needs to be aware of. Sarcoidosis is also reported. And this is, again, that European registry that we have contributed patients to. So mediastinal lymph nodes, all patients had that. Extrathoracic disease in about half of them. And it's very common to see skin sarcoidosis and nodules in these patients. We have seen a few, and most of ours actually had those, had skin involvement and nodules, which is not as common in primary sarcoidosis. So this is a patient that we saw that had nodules over the flexors and extensors of the hands. And very interesting, he developed small nodules all over areas where he had tattoos. This is another patient with hilar adenopathy, the subcutaneous nodules, and arthritis of the ankles. So other rheumatic immune-related adverse events are more rare. Lupus has rarely been described. Vasculitis, there are some cases, and there's also scleroderma-like lesions or Raynaud's that have been described. We have contributed to the registry, the European registry, against some cases of vasculitis that we saw in our center. And the registry has found 28 altogether. The important thing here, the majority were small vessels, and most of the pathology was unclassified. So there were a few that had Wegener's or EGPA, but the great majority was non-specific small vessel vasculitis. Crystal arthritis, this is not autoimmune, but it's inflammatory, and there have been reports of gout flares and reports of pseudo-gout flares. We had a patient, which was the first patient that we had with crystal arthritis, who was very interesting because he had repeated monoarthritis of his knee, and he had crystal. So we ended up giving him colchicine, and he did very well and was able to continue with nivolumab. Unfortunately, they changed his immunotherapy later on, and then he developed PMR, but he didn't develop the pseudo-gout anymore. But now he's doing fine, and his cancer is gone. So it's a happy story. But it was interesting because every time he had the flare after the nivolumab, we would tap and there would be crystals. And then with colchicine, that was gone. Osteoarthritis, it's also been described that there can be flares of osteoarthritis after immune checkpoint inhibitors. So that's important to remember because these patients perhaps do not need as strong a treatment or as aggressive a treatment as in the cases where it's purely inflammatory arthritis. And this is a paper done in one of the databases that we have, the Optum Clinimetrics database. And it's a paper that we work with someone actually at the University of Alberta, Carrie Ye, who's involved in the CanRio database also. So we examine fractures before and after receiving immune checkpoint inhibitors in patients with melanoma. And what we found was that, and I apologize that here you cannot see the numbers well, but it almost doubled the risk of fractures in the year after checkpoint inhibitors. And this was not associated at all with the receipt of corticosteroids. So we found no association with the dose of prednisone. So let me talk a little bit about the challenges in management. What we want to do is limit mortality, overall mortality and morbidity. But one of the major, and I know that I've been repeating that often in this talk, but it's to try to continue the checkpoint inhibitor because this can really be life-saving or at least prolong life for many patients who don't have any options. So we always have that in mind. Let's try to get the patient in such a way with whatever treatment we can so they can continue to receive the checkpoint inhibitor and try to give them treatments that will not impair that efficacy. So how do we get evidence as to whether these various treatments actually can impair the immune response or not? So one of the things we can do is first look at patients who have autoimmune disease and cancer without looking into checkpoint inhibitors and see if in these patients who have cancer that we are treating with different agents, is their cancer worse when we treat them with these agents? So it's kind of indirect evidence. And there's not a lot of information. Most of the studies are in rheumatoid arthritis and inflammatory bowel disease. And then the second thing is to look at patients who are actually receiving the checkpoint inhibitors and who receive immune-related and who develop immune-related adverse events and are treated. And those series are even less frequent than, or there's less studies looking at that than what there is looking at patients in general who have autoimmune disease and receive these agents when they have cancer. It's very difficult to study. There are many biases. On one hand, there's indication bias. So it might be that some patients with more aggressive or less aggressive disease may receive more one type of treatment than another. And then, as I mentioned before, in those who have immune-related adverse events are associated with a better response. So if you are giving an agent that would be associated with a worse response, that may balance out, so then you don't see the impact of the drug being deleterious simply because the patient is having an immune-related adverse event, which means that their immunity is more active and also fighting against the tumor. So difficult to study. So this is a study that just in patients with rheumatoid arthritis that received tumor necrosis factor inhibitors or TNF inhibitors, and they looked at cancer recurrence. Most of these patients were cancer survivors, so they were not treated early on, but they found again, this is not checkpoint inhibitor, it's just patients who received TNF inhibitors in the Swedish registry, and they did not find any signal that TNF inhibitors were deleterious. We did this study also ourselves, and this is very busy slide. So these are using databases here, Medicare and Optum Informatics. So I mean, don't look at all the busy stuff, just look at the lines here. We looked at patients who had breast cancer and received TNF inhibitors. They have rheumatoid arthritis also, received TNF inhibitors in the first couple of years right after the diagnosis of breast cancer. And we control for a number of variables. I mean, with claims data, you can't control for so much, but we did not find any signals that TNF inhibitors received right after cancer diagnosis were deleterious. We've done the same for the other three most common cancers, so colorectal, lung, and prostate. And again, we don't find any impact of TNF inhibitors received during the first 3 years of disease. If anything, in some, they might be a little better survival. And again, we control for various things, but we don't see a signal for TNF inhibitors. We haven't looked at the other agents. So if we look at the data in patients who receive checkpoint inhibitors, we know that the worst tumor response in patients who are receiving steroids at the onset of checkpoint inhibitors. So let's say they had asthma or they had rheumatoid or whatnot, and they were receiving steroids for another reason. When they start checkpoint inhibitors, their response, the tumoral response is going to be worse, possibly because the efficacy of the checkpoint inhibitor is not going to be as good as it could be. TNF inhibitors appears not to have adverse events, but there are a couple of studies that showed perhaps worse outcomes, but most of the studies have looked at patients who had colitis, and for colitis, they only get 2 doses of infliximab, and that's that. For ICI-induced arthritis, they might be on TNF inhibitors for 2 years, so it's a little different. IL-6, again, it's thought to be deleterious for a tumor, so conceivably IL-6 inhibition could be better for the tumor, and that's what our oncologists prefer that we use, but there's more data that's needed in humans. And then the effect of steroids versus other DMARDs. And that's where we tend to be perhaps more concerned, although we use steroids a lot because they are very fast acting, and in some cases they are needed. So this is a study that was done in patients with arthritis. This is 147 patients treated for arthritis after checkpoint inhibitors, and they compared this from several centers, and one of the centers was MD Anderson, and they compared methotrexate, TNF inhibitors, and IL-6 inhibitors, and what they found was that those who received methotrexate, that's the line here, did actually better than those that received the other agents. But this is a small sample, and there were, many cancers, so it was difficult to control with such few numbers. But in arthritis, it seemed to be to some degree worse if they received that. Corticosteroids. Patients with cancer often receive corticosteroids for many other reasons, brain metastases, advanced cancer, supportive care, or whatnot. Conceivably, they can impair the tumoral responses because they cause much broader immunosuppression. We often use them in patients with pre-existing autoimmune disease who get cancer because of the quick response, and if they are getting chemotherapy or another treatment, we want to use them at bridge therapy. And our own studies that have looked at TNF inhibitors in patients with early cancer, we don't find signals from the TNF inhibitors, but we find worse survival for those who received steroids on the first year. And we control for stage of disease, we look at stage 1, stage 2, but if they receive steroids, there is worse survival, which we don't see with the TNF inhibitors. So, the data is a little conflicting. It seems that doses over 20 milligrams per day are the ones that should be most concerned about. So, steroids have been used, as you know, for many diseases. So for lymphoma, leukemia, they are actually therapeutic. And for prostate cancer, they are also used as part of some treatments. So in some cases, steroids are actually not bad for the cancer. In other cases, there have been studies that have looked, for instance, triple-negative breast cancer, and the effect is harmful. This is a busy slide, but just to show you here, this is what immunotherapy does, and this is what corticosteroids do. So they basically do the opposite of what immunotherapy does. So, increase activation and proliferation of tumor-reactive T cells, reduce memory, CD8 positive T cells, increase immune cells, decrease cells, increase pro-inflammatory cytokines, decrease inflammatory cytokines. So pretty much because they have such a broad spectrum, they impair or inhibit all of the pathways of immune stimulation that checkpoint inhibitors improve or enhance. So what we know from the data that has been published, baseline steroid use, as I said before, tends to be deleterious. Early high-dose steroid use also is associated with worse outcomes. When used later on for immune-related adverse events, the data is conflicting. But again, we don't know if it is because the patients who have immune-related adverse events are already going to do better because of their enhanced immunity, and any effect of the steroids gets masked by that better prognosis that they have. There's a meta-analysis that was done of several studies, and it showed that the comparing patients who received steroids versus those who did not, worse survival and worse numbers for progression, 1.5 and 1.3. And these are the forest plots, and you can see here that this is the deleterious effects of all of the studies that they looked at. So steroids seem to be bad in general, especially high doses and early on. So now I only have a couple of, just 1 minute to show what we are doing with our IOTox initiative. These are the numbers of patients who receive checkpoint inhibitors at MD Anderson. So it's increasing, and the last number that we have was close to 5,000. Because of that, there's also an increase in all of the adverse events, and this is rheumatic adverse events. So there's been an increase between 2019, 2022. So we created this IOTox initiative that started in 2019, and we have different aspects of it. The most important one, I think, has been the clinical one, because we have created smart sets, referral forms, and a number of things, patient education materials to use in the clinic. The research is just starting, and we also have some professional education activities. We are having a symposium next week, so if anyone is interested, it's going to be offered by Zoom, and you can register. It's open to everyone. So the other thing that we offer that you can see is our algorithms. Some of them have been validated and they are public. So if you go to our page, you can see our algorithms that we use for immune-related adverse events. This is how they look at. This is just for dermatitis. for arthritis, they have not been validated by our effectiveness committee, so we are waiting for that. But that's basically what we're doing at MD Anderson. So in summary, rheumatic immune-related adverse events happen in about 7% of the patients. They are more common in those who receive PD-1, PD-L1 monotherapy or combination therapy, can occur late. They are hard to treat and can be sustained for many, many months, even after stopping therapy. Myositis is the one we worry about, especially because of myocarditis. And management, the safety of different agents is still unclear, but we tend to shy away from high-dose steroids and try to use DMARDs early on to avoid the potential deleterious effect of steroids. Thank you.
Thank you. Thanks for this outstanding presentation. Congratulations on everything you've done advancing this field. Are there any questions in the audience here? I invite people to enter their questions in the chat. Otherwise, are there any questions in the audience? Yes, Kaveri.
It's wonderful. I've learned more in an hour than I could. Comment on osteoarthritis, why checkpoint inhibitors would cause exacerbations. I mean, I know there's an inflammatory component.
Yeah, mostly because there is an inflammatory component to osteoarthritis. I mean, patients with osteoarthritis of the knee have swollen knees, and that's because they have inflammation. So by causing unrestrained inflammation, which these agents cause, there might be an increase in the symptoms and cause more inflammatory osteoarthritis. I mean, it's the same reason why do they develop gout, or I've seen patients with tendinitis of the shoulder where they have gone worse with the immune checkpoint inhibitors after the infusion, and they might say, a week after the infusion, I'm feeling worse, but then towards the end of the month, I'm a little better. I mean, these are not just autoimmune effects. We tend to say autoimmune, but they are inflammatory effects, and many of them can be just related to unrestrained inflammatory effects, rather than autoimmune effects.
Mark Roger?
Yeah, just a quick question. So any relationship between these agents and developing antiphospholipid antibodies and thrombosis?
Not that I know of. I think there's been a couple of case reports, but not that I don't think that we have had any ourselves at MD Anderson, but I think there might be reports. I mean, antiphospholipid antibodies are increased in patients with cancer, even if they don't have autoimmune disease, when you compare them to the general population. Because, we've done a meta-analysis of studies looking at that, and there is an increase in antiphospholipid antibodies in patients with cancer without any evidence of other diseases. So it would have to be controlled, to see if it's the checkpoint inhibitor or just the increases in antiphospholipid antibodies that we see within cancer.
Sorry, there's questions in the chat. There's a question about inflammatory arthritis, whether it occurs later or whether it's just a delay in recognizing it as opposed to rash and colitis.
Yeah, I don't think it's a delay. I think it occurs later on. Why? I don't have an idea. I wish I knew. But I don't think it's a delay in recognizing it because, we've had patients who have developed arthritis even after stopping the checkpoint inhibitor therapy, and not just arthralgia, but clear synovitis, and we've treated them and they have responded, and then eventually they got better. So I don't think it's lack of recognition. It happens later on. I don't know why, because of the persistence of the symptoms. Might be more of an autoimmune effect in these patients than colitis or rash, which might be more innate immunity and more non-specific inflammation rather than autoimmunity.
There's another question on the role of JAK inhibitors.
There could be. JAK inhibitors are very, very effective. The one thing with JAK inhibitors is that And you might be aware of this. There was a trial, the oral trial that was requested by the FDA comparing JAK inhibitors to TNF inhibitors. And they showed that there was an increase in the incidence of cancer in the patients that received JAK inhibitors compared to tofacitinib specifically, compared to patients who received TNF inhibitors. So there's always a little bit more of a concern in using JAK inhibitors in patients with cancer, I would say. The other thing is that for some adverse events, biologics, I mean, tend to act a little quicker than JAK inhibitors. So from that perspective, it could be more effective in short term.
We'll take one final question about IgG development, antibodies that develop after receiving treatments.
Very interesting. I'm not aware of that. I guess you're referring to neutralizing antibodies against the checkpoint inhibitors.
What did he say?
Yes.
Yes.
Yeah, I have no information, I'm sorry to say, about neutralizing antibodies. But I mean, these are all human antibodies or human. I mean, they are not chimeric antibodies to my knowledge, the majority of the treatment. So the probably the development of antibodies against these agents would be lower than for other types of monoclonal antibodies, but it's not a topic that I know about.
Okay, so we are up. It is 1 o'clock, so we will have to close the rounds. Thank you. First of all, congratulations, fantastic
you.
work. Thank you for sharing your algorithms online. Maybe we will enter that website in the chat if I can ask you to enter that so that people can access it. And thank you very much. A very big thank you for coming to Montreal and joining us today for these
Well, thank you for inviting me.
Thank you.
Thank you.